So this was what was the picture which I saw on diagnostic nasal endoscopy. You can see the atretic part of the choana. The atretic part was mixed. That is, this choanal atresia was a mixed type with both bony and membranous. In the left nasal cavity, we can see that the nasopharynx is patent, and I can see the hypertrophied adenoid. The CT nose and PNS showed a mixed type of choanal atresia. We can also see the right myelosinusitis. In the coronal view, we could see the right choanal atresia along with a septal cell, which was also causing the choanal atresia. First, I tried to confirm whether I could break the bony part of the choanal atresia, but it was very solid. So we proceeded with the nasal decongestion. Here I'm using a 4 endoscope, so nasal decongestion becomes very important in pediatric age groups. Outfracturing of the inferior turbinate. So as to increase the space, which is very important in this kind of surgery. Local infiltration was given along the septum. In this case, I have made use of a septal crossover technique. Sufficient infiltration was given along the septum. I, I proceeded with the next step, that is raising of the nasal flaps. In the left nasal cavity, I gave the incision so as to elevate a superiorly based pedicled posterior septal flap. I made use of ear microsurgery instruments. Here I'm using a double end knife so as to elevate the mucoperiosteal flaps. I can see the underlying bone. I make sure I don't tear the flap. I elevate this superior base pedicle flap completely. I have kept a Boyle Davis mouth gap in the mouth. The reason being that in between I would want to confirm my position by using a 70-degree endoscope so as to visualize the choana. Here you can see I am slowly starting to elevate the posterior septal flap. I tuck my posterior septal flap superiorly so that there is no chance of injuring it when I use the neurosurgical drill, skull-based drill. I then repeat the same process on the right nasal cavity. the side in which the nasal conal atresia is present. But though, but as but we elevate a inferiorly based pedicle flap on this side of the nasal cavity. So my superior based pedicle flap from the left nasal cavity will be utilized to cover the bone in the superior aspect, while the inferior based pedicle flap will be used to cover the floor. So here I've elevated the inferior pedicle flap, which I tuck in below the level of inferior turbinate. I I remove the part of the septal cartilage as well as the vomer. Remove part of the septal cartilage as well as the bony part of the nasal septum. I make use of different methods. We can use a chisel, or even we can drill the bone. A posterior septectomy is very important in such cases to prevent restenosis. Hmm. After the flap is completely elevated from the septum as well as the atretic plate, we can start the drilling of the atretic plate by using the skull base drill. So here you can see that I have removed quite a bit of the septum, and now I can visualize the nasopharynx from even the right nasal cavity as well. In this case, as soon as I remove the posterior part of the septum, a part of the atretic plate also broke off. We can visualize the atretic plate here, a part of which is already broken. I made use of skull base drill again to drill this portion as well. I used a debrider to shave off the excess mucosa covering the atretic plate. We can see the nasopharynx now. We can see the hypertrophied adenoids. Hmm. I again used the drill to smoothen the region. We should go from medial to lateral. We should not go too lateral towards the pterygoid, otherwise the patient will end up having trismus. We get a nice smooth cavity. I did an adenoidectomy with a microdebrider. I've not tried to be too radical with the adenoidectomy. I have replaced my superior base pedicle flap over the raw bone, while the inferior base pedicle flap has been utilized to cover the floor. Hmm. So here you can see I have removed sufficient posterior part of the septum and removed sufficient part of the atretic plate so that I can, even from the right nasal cavity, I am able to visualize the nasopharynx properly. This patient will be on regular
So
follow-up